computer, it should be underneath you. And I'm also letting you know that the meeting is being recorded, as you've probably just been alerted. If you want to change your names or anything, please feel free, but the recording will just be our faces, and then there'll be a transcript of the chat, so you shouldn't kind of be in it too much. Other than that, if you have any issues and you need to leave the call, just rejoin from the same link. Somebody will see you in the lobby and rejoin you in. And that's hopefully going to be a fairly smooth running. Questions, please feel free to message me directly or put them kind of publicly in the chat. If you want, you should have options to do both. Fingers crossed. Other than that, just time to introduce ourselves. So for those of you who haven't been to one of these before, my name is Jo Southall. I am an independent occupational therapist, and I also happen to have hypermobile EDS, POTS, and a load of other random bendy stuff. So my kind of area of specialism is around coping strategies and symptom management. I've been doing these live streams for a very long time now, and I'm delighted to have a special guest with me this evening. Would you like to introduce yourself, please?
Of course, thanks, Jo. Hello, everyone. I am Reema. I am a physiotherapist. I've been a physio for, goodness, over 15 years. I have been invited today to speak to you about all things kind of from the physiotherapy aspect. I run my own physiotherapy clinic in Northwest London. I also work for a company called APOS Health, which is a foot-worn device, which basically helps conditions that, like, you know, all things hypermobility and kind of proprioceptive, which I'm not sure everyone knows that word, but we'll come on to it later. But a way to manage people to reduce need for surgery or onward therapy if other therapies haven't worked. So that's me. I'm a Bollywood dancer and an actor too. So and I also do have hypermobility myself. So I have it's been undiagnosed for a long time, and I self-diagnosed myself when I became a physiotherapist because it was something that osteopaths couldn't see through. So that's me.
Thank you very much. I've met a surprising number of people who had like mystery joint problems, started training as a physio and went, oh, that's what's wrong.
Yeah. I think a lot of people actually did it the other way around and had kind of issues, and then actually went into the occupation because they, you know, were able to diagnose themselves and other family members. So fell into the job role.
Okay, so I do have one pre-asked question, and then which is slightly more of an OT focus, and then we've got quite a lot of, I can already see questions racking up in the chat. So this will hopefully be a bit of a whistle-stop tour. So my pre-asked one was, are there any super low energy activities and recovery activities that are good for staying occupied all day? Being able to get through the day less bored and restless would be a huge boost. So this is for somebody who spends the majority of time in bed for symptom management reasons. So yeah, I think from my perspective, I try to avoid classifying all activities by like whether it's restorative or not, because I think there's a very fine line between something being restorative and you having done 5 minutes too much of it and it now being a problem activity. So I try to think about less choosing activities that are low energy and more what activities do you enjoy and how can we make them low energy. And sometimes it's about just doing less of it. So actually, if you're doing an activity, craft work for a lot of people is a good example. Setting up for it, taking a break, actually doing it, taking a break, tidying up, taking a break. And sometimes it's more, you know, learning to factor in your own self-management stuff. So if I'm doing a lot of crafty work, or if I'm reading, or I'm on my computer, and I know that's going to be a lot of time hunched over, fine motor control stuff. Sometimes it's not about resting, sometimes it's about moving to get me going from that. So it might be a great time for some gentle stretches, or a little bit of physio, or even just time to blink and release the grip I've had on whatever craft tools I'm using so my hands don't get stuck in T-Rex mode. So, you know, I think for me, a better question is sometimes, what do you actually want to do? What do you like doing? Is there something you miss doing or something you want to try? And then what are the ways we can break that up or simplify it to make it slightly better accessible? Thinking about your workspaces can be really helpful there. So I'm actually in bed at the moment because I figured from a POTS management perspective, I'm a lot more functional if my feet are up. I just am. So all of my work, all my consultations, all of my like academic stuff is done in bed or on the sofa. And having a desk that goes all the way over the bed and down either side, but is angle adjustable, has been a game changer for me because it means I can do stuff in a workspace that changes angles depending on how my bed is set up and what postural needs I have. So yeah, sometimes it's less the specific task and more the how are we doing the task. Equally, working up to a task in terms of maybe you're not fit enough for it right now, but could you be fit enough for it in a year with a little bit of training, a little bit of targeted rehab? Different question. So I hope that's sort of useful. Please feel free to ask follow-up questions if you have them about that. Anything to add there?
I would have, because you talked briefly about pacing, and I would say the kind of to preempt um, a moment of overwhelm, because I feel like the work I do is often around kind of just wellness and well-being. So sometimes it can feel quite overwhelming for someone to manage their energy level to the point of completing or even starting the task. So kind of the mental preparation, so what that requires, because that also will take and use our energy, sometimes too much before we even get to the point of completing or even starting the task. So the only thing I would add is, what are we doing to help us to prepare to get to that point, from a mental health perspective? And is that just something that we need to do ourselves independently, or is it something that we need to talk it through with another therapist or even just a family member or a friend? Because I often find when I'm getting myself into it is with a task that I'm not sure how to manage, just speaking it out loud to someone often answers my question, even if they haven't given me a solution. So that for me is probably just my ad.
Fabulous. Thank you very much. So, next question definitely falls into your remit, I think. So, do you have any tips for working out how much physio to do when there's a big difference between what you can do with and without joint supports? Should you aim to do less without or more with them? And does that answer change for compression versus more restrictive kind of splints and braces?
Good question. So again, I would say, we always talk about kind of in physio like comorbidities or pre-morbid condition. It sounds like it doesn't sound like a very nice word, but what we're talking about is what was your ability before, because we're all different, aren't we, in terms of if there's no blanket kind of answer to that. So it really does depend on what you can manage before the task. I would say with any condition such as, was it for heads or was it just any?
Yeah.
So the more support I would say protecting the joint is key. So if we don't have support, and if you're used to not wearing support and you don't have symptoms, then go by managing very slowly and gently. But the kind of the extreme of that is if you have a support and you're going to push yourself and then feel the effects afterwards, and it's actually too hard to handle and it's too challenging for the joint, then that will kind of almost be the extreme. So I'm not explaining myself very well. I would say each person is different, but dependent on whether you have, I would start very slowly, and support or no support, it really does matter what condition, what we're managing, what exercises we're doing to even prepare to complete the task.
Lovely. I think symptom diaries can be really useful for this. So if you're starting out with a new rehabilitation program, or you are stepping up the intensity, or you're increasing your amount that you're doing, or even if your rehab is staying the same, but another aspect of your life has become more intensive, actually documenting how you're feeling can be really useful. And it's
Yeah.
sometimes not as simple as I did 5 reps, now I've got backache. Sometimes it's I increased things slightly and 24 hours later, I randomly have a new injury. Do you know, so spotting the difference when you're not documenting things can be quite difficult. Whereas if you've got that extra data about how you've been feeling, what you've been doing, it sometimes makes it easier to spot patterns.
Mm,
From a compression perspective, one of the things I really like about custom lycra garments is that they're not restricting you to the point where you can't do bendy movements. What they're doing is encouraging you to do things the way you're supposed to be doing them, which I think if we've got, proprioception coming up again here. So proprioception, if you have good proprioception, is what allows you to know where your body is enough that you can safely walk through a door frame without hitting the sides. Bad proprioception is when you try to walk through a door frame and get the door handle down your dressing gown sleeve and then trip over your own feet and spill hot chocolate on yourself, as
mm,
an example. So that if you're struggling from a proprioceptive perspective, protecting your joints is going to be that really key thing. And the compression for me is like a hybrid between not having splints versus completely restricting how far you're pushing yourself or moving. The only exception I would say to that would be if you actually have an injury to one part of yourself that needs really intensive protection, you really want to be looking after that.
mm,
So slightly more intensive splinting is a good way to borderline immobilize bits of you, but allow you to still exercise the rest of your body, because we all know how fast that deconditioning thing can sneak in. So being able to work around injuries for those of us that are injured the majority of the time is a really, really good use for splints and braces. Fabulous. Okay. Uh, I'm looking for advice on when requesting OT referrals. I find you have specific issues looked at rather than a full assessment, and then you're discharged and have to refer back if further need. So the question was whether that should be the case or not. It's for my son and whether you can ask them to do a full assessment. So assessment means different things to different therapists. There are tools that you can use in a formal assessment perspective, but equally, when I do assessments, what I mean is a conversation. So it is going to be quite varied. Often when we see assessments, if you're looking at something like in the HCP or you're looking like a formal kind of capability assessment for a particular task, that would be slightly more formal and slightly more structured. Not everyone does things that way. And within the NHS, often because of some kind of funding wizardry that I don't fully understand. If you're referred for a specific task, the funding only covers the referral to deal with that thing,
mm,
which is a problem because you then have to get re-referred for another thing because the funding comes out of a separate pot for that. So one way to sort of get around that is when you request a referral in the first place, request the referral to cover every single aspect that you can possibly think of in the hopes that when you get to see your person, you're actually allowed to deal with multiple issues. As far as like private services go, we're not restricted in the same way for funding purposes. So you're allowed to kind of come to me with one issue and we'll see you for another issue if the other issue has become more emergent, kind of thing, which is one of the many reasons I don't work for the NHS. But yeah, you can request it. Whether or not they're able to do it within that service, is a separate issue. And there may be some kind of yeah, jiggery pokery kind of required to get you allowed to do that, basically. So it will be partly up to your GP. If you don't feel like it's being taken seriously and your GP can't get an answer, it's worth speaking to PALS to see if they can get you something slightly more comprehensive in terms of support. But yeah, hopefully that's at least a little bit helpful. Anything to add?
no,
Mm,
sounds good.
okay. Okay, I am ASD ADHD heads and wondering what the best symptom management regimes for strength building. I'm told since losing 5 stone that I have less support around my joints, so needing to build muscle, but struggling to know what I'm able to do to gain muscle.
Mm.
Any advice?
So ASD, sorry, what does that stand for?
Autistic spectrum disorder
Oh,
conditions,
of course.
autism, ADHD.
Um,
Yeah.
so I would say, first of all, don't please use Dr. Google. because often it's a very kind of niche treatment for you. And often when we're looking at things online, you're going to be given exercises or something that might be high impact, that's putting more pressure through your joints. So one thing I would say is try not to kind of search too much online. It definitely does need a therapist to kind of have a look at you, have a look at how you move and stand. Often it's I do gait analysis, and so I watch someone walking and moving and have a look at what's kind of giving them the issue, whether it's coming more from the ankle, the foot, further up into the knees, into the hips, etc. And that often gives us some information as to what muscles might be overworked, or need more manipulation. So for yourself, I would actually start with some kind of like very slow kind of muscle energy techniques to see whether that in a seat in a most comfortable position for you, whether that may be kind of with your back against a wall, or sitting down or leaning up against something, so that your body is being well supported. The other thing is to make sure that you're allowing yourself time. So we talked about pacing, but also not pushing yourself to the point where you're having to do loads and loads of reps in a go, because you may want to be, your mind might wander and you might want to go do something else. So give yourself 3 minutes, time yourself, or put your favorite song on. I do that. And I would do exercise to that song, because it will make me feel calmer, so I don't feel the pressure of doing the exercise. And before I know it, I've done 5 minutes, which actually becomes easier and actually really quite enjoyable. So muscle energy techniques is like a hold, relax. You can do that in any position. And then you can build up. So if you know your foundation and you know where your body is comfortable, and you can then see what it feels like afterwards. We mentioned about how your symptoms are kind of day one, day two, then you can build up on that. So it's a very slow, progressive type of exercise treatment plan, where you're allowing your body to kind of get used to these movement patterns. And if you like a certain activity, for instance, I'm going to use dancing because I'm a dancer, then find an activity that you enjoy. I'm not going to go out running because I'll probably trip myself over, and I often do, on paving stones, but I would dance, and I can do that for an hour and feel comfortable. So those I probably would say our top few tips.
Lovely. I think one of the things that's going to be a challenge, for people who've been through any significant body change, so weight loss is a good example, but anything that's drastically changed how your body reacts, even things like changes of medications, or if you're used to being in a lot of pain and you find something that actually reduces that, sometimes you almost don't know how to function without being in pain for a while afterwards. So this is particularly a problem for the neurodivergent crew because of something called interoception, which is basically your body's ability to understand internal feelings and signals. Now, one of the difficulties that a lot of autistic people have is that it's very hard to pick up on things like hungry, thirsty, backache, need the loo. What you instead get is a vague feeling of something is not right. I don't know what it is. I am dysregulated, or I'm uncomfortable, or something. So there is going to be a process for you of getting to know your body as it is now. And that might take a while, and it might be unpleasant, because the more attention you pay to your symptoms, the more you notice you have a lot of symptoms. So what I would say is don't rush into anything. And if you're going to make a change to your routine, make this much of a change. Because if you make this much of a change and it turns out that thing isn't suitable, you only get this much of a flare up. Whereas if you go straight to, I don't know, 3 hour boxercise sessions or high intensity or a spin class, and that's wrong for your body as it is right now, the payback from that is going to be really unpleasant. So whatever you try a little bit of it. If the lack of support is a persistent issue, adding compression clothing can really, really help. Things like kinesiology tapes as well can be a good way to give yourself some of that feedback that you're now lacking. I would also maybe suggest water-based exercises, because water adds support, but it also adds resistance. So you're getting quite a lot of like, yeah, you're getting quite a lot out of it for the amount of energy you have to put in, basically. Equally, swimming pools tend to be fairly cool, whereas hydrotherapy pools tend to be warmer. So if you are on the potsy end of the spectrum and you don't tolerate heat particularly well, exercise classes in regular swimming pools are often a little bit more tolerable than proper hydrotherapy. So I hope some of that helps too. Lovely. Need a recommendation for shoe websites that support bespoke orthotics and don't look ugly. Um, don't we all? Uh, um, I'm trying to think back. I've been like a die-hard Hotter fan for a long time. You know, there's a little bit of an old lady vibe to some of the designs, but you know what? I'd rather be comfortable and functional than
Agreed.
like stylish and not able to go anywhere. Skechers also almost always have removable insoles, and the insoles that are in there tend to be memory foam, meaning that if you wear your orthotics with them long enough, they will squish to permanently accommodate orthotics, which is kind of handy. Yeah, it's not an ideal situation.
Mm,
Um, if it gets super desperate and you've got orthotics that genuinely do not fit in any kind of shoe, you can get prescription shoes to accommodate orthotics. Again, the ugliness will be an ongoing issue. Um, you could also, if it's the width that's the issue, potentially try men's shoes over like women's shoes, or wide fit over standard fit, that kind of thing, if that makes a difference. But it's not really an ideal
mm.
situation.
Someone just mentioned in the comments sketches, which I find can be very useful when they are not kind of just a slip-on. I often find that if someone's wearing a slip-on, which if it's easier to get on because of finger dexterity, etc., then I understand functionally it's a good option. Having said that, a slip-on doesn't support the ankle, and I often find if someone's going to kind of, if they're more at risk of pronating or going over on their ankles, then they are increasing that risk. Often they are also quite low underneath the malleolus, the ankle joint, which can then increase the risk of going over. So I suppose with any, sometimes I've had people come with all sorts of shoes and all sorts of brands. I often find that the big brands out there have quite a narrow fit, which naturally don't work for insoles, or just toes that have kind of moved out of kind of their alignment. So always go and just have a try. You can go to some of these shops and do a gait assessment and see what on our treadmill, and see how they analyze how your foot falls. Sometimes a very hard sole can be not very shock absorbing. So I often find that a thicker sole provides a little bit more shock absorbance, which will support you all the way up to your back.
Swapping out regular insoles for gel insoles, or like
Mm,
basically just better insoles, is often a good move as well.
yes.
I agree with the shoelaces thing. If
Mm,
you struggle with laces, elastic laces are a thing, and magnetic laces are also a thing, but they will still give you fractionally more support than not having lace-up shoes at all. So yeah, definitely go down that route as well. Um, there's a request in the chat for an online EDS friendly Bollywood dance class. If you wanted to set that up, that'd be great.
well, okay. If there is the market for it, then I'm available.
Fabulous. Sign us all up. Somebody's asking about my glasses as well. I did have custom color tints for a very long time, but these are actually a generic, because the generic happened to match my precision tint to the degree where it saves me a couple of £100 but makes no visible difference. So I got quite lucky there. So visual stress does seem to be quite a common thing among neurodivergent groups, but also among hypermobile groups because of the massive overlap of those two groups. So I have particular issues with light sensitivity, constant kind of visual static, and I don't have functional depth perception, which is super great fun when you already fall over for a whole host of other reasons. So as a kid, was basically functionally illiterate until I was 12. So yeah, they've made a huge difference to me in terms of quality of life.
Right.
Yeah, definitely If you find that like glare from light, light to dark adaptation, looking at stripy patterns or reading off glary white paper are a problem, get yourself tested, particularly if you have persistent headaches or migraines. So yeah. Okay. Are people with Marfan syndrome and HSD slower to build muscle, or does it take longer to progress with PT in a hypermobility disorder?
I think in terms of building muscle, it's more about the connective tissue being more, it allows for more movement. So it can be, it's less so about the building of muscle because we've all got what we've got, but it's how if there is an injury, then we are more at risk of longer healing processes, for instance, or bruising and things like that. So it's just about finding a different way to manage, support that muscle, because you may find that it does waste or atrophy sooner because of the way the condition, kind of like supports or doesn't support your body. So I would say that it's finding a way to manage it through the period. Going back to proprioception, if you haven't got that ability of knowing where your body is in space, so if I was to close my eyes and take my finger to my nose, poor proprioception might, almost like put, affect where my finger goes. Or if I was to stand on one leg and close my eyes, I might not be able to hold my balance as much as if I was using my eyes. So in the same way, it's a package. It's everything. So if we can find other ways to manage that, i.e. doing some eye closed exercises and being comfortable, but to increase that proprioception, then it will support the muscles and keep the tone. Does that make sense?
Yeah, it does. Yeah, yeah.
Okay.
Yeah, I think, yeah, a lot of it, I think, generally I'm of the opinion that it's underappreciated how much of a difference bad proprioception makes by
Yeah.
like, most people in general. I think it really significantly comes back to a lot of kind of functional difficulties that you just don't know where your own body is. You don't know how you're moving. You can't not connected to your body in the way that you need to be to successfully carry out a task. So, um, yeah, anything you can do to improve proprioception is definitely a good thing. And again, that's why I'm such a fan of compression for exercise purposes, because it does give you the feedback you need to exercise safely.
Mm.
Things I've noticed when I've compared like rehab stories with some of my non-hypermobile friends is that they tended to have a really linear recovery in a nice kind of gentle uphill glide, whereas mine tended to look a little bit more like a roller coaster.
Mm.
So if one of the things you can do to support that rehab journey is avoid that two steps forward injury setback kind of progression, it feels like you're making progress a lot faster and a lot smoother and is obviously much less unpleasant in terms of injuries and things as well. So um yeah, proprioception.
Ooh, I'll add one more thing. I would also add, don't be afraid to use apparatus. I do Iyengar yoga and I love it because I can use a wall for feedback if I don't know where my body is. So I can, I have other means to improve that proprioceptive feedback. So it's all about finding things, maybe it might just be, two fingers on a table, for instance, to help manage a stretch or help manage an exercise or even just stand. So I think the more we can get used to using what we have around us and being comfortable with that and not comparing ourselves to the next person, the easier the rehab and management of muscles would be.
Yeah, love that. Exercising, I always, whenever I learn a new physio exercise, I do it in front of a mirror to start with.
Mm,
And it's a really good way to be able to spot if I'm dropping a shoulder or if I'm putting pressure in a weird way or my knees are going backwards. And then to learn what that feels like to the point where I'm then safe to do it without the mirror.
brilliant.
Um, the other one was I had a load of like on like hands and knees kind of tabletop like exercises, and I used to do them directly under a lamp so that I could watch my shadow.
That's clever.
So that was quite a handy one as well. So yeah, fingers crossed some of that helps. Lovely. Likewise, if you do have exercises where you can't watch yourself, having somebody else watch you, and if you start to lose your balance a bit, they can just kind of prod you back into the center. Really
Yeah.
helpful. So, bring a person to physio or exercise classes and get them to learn what you're supposed to do. So, yeah. Question from Jane. My question is about swaying from the pelvis up the back after walking. What's causing it? So also extreme pain, SI joint osteoarthritis, S symphysis pubis osteoarthritis, and back osteo as well.
Hmm. So I don't want to keep going on about proprioception, but so if the sway, so as we're walking, just to explain what I understand is that there's a little bit more of a meandering gait, a little bit like a model. Often that's pelvic weakness, and if there is, as you mentioned, there's SIJ, osteoarthritis, the sacroiliac joint, for anyone that doesn't know the SIJ, it's all connected. So if we've got the bottom, if they've got the bottom tailbone, that connects all the way up, and then it connects to the pelvis, which connects to the lumbar spine and all the way up into the back. You've got the big glute muscles that provide a lot of stability, but if they're not switching on as quickly or as well or efficiently as they should be because of underlying hypermobility, then there's going to be a mismatch. So often it's the connection between what the bone's doing and what the muscles are not doing. And this is why it's really important to find that kind of middle ground. So, I mean, we don't, I use the word core very loosely because most people think it's the abs and like what people see in your Instagram reels, but it's not just the front muscles. It's the whole unit. It's coming from the glutes, coming from the hamstrings all the way up and up into the back. So the whole core is literally our middle section of our body. If that's not as strong as it can be, and strength, I mean when it needs to be in coordination to movement. And if that isn't, then you're going to get that sway. And again, from going back to what I was mentioning about gait and watching someone walk, I use an app, and it will give me numbers, and it gives me values as to how long or the percentage of time someone spends on the left leg compared to the right. What that tells me is how much of a sway they have. People with hypermobility and hypermobility syndromes will have a longer time spent on one leg because it takes longer to get off one leg to get onto the other side. And it's just a fact. So what the thing we can do mostly is try to engage the core, try to engage that middle section of the body, whether it's coming from the glutes up to the back, bringing in the navel, all the things you mentioned, like on hands and knees and in tabletop position can help, so that you're nice and secure on the floor if you're comfortable kneeling and with your wrists in kind of a flexed position. But there are things you can do to protect the back, and protect the glutes and protect the pelvis, so that pain is less and coordination is improved.
Lovely. From a back pain perspective, if you haven't tried a TENS machine, I would strongly suggest that you do. Wearable drug-free pain relief, if you're living with almost constant back and pelvic pain, is a game changer for a lot of people. And if you are less distracted by the vast amounts of pain, you are better able to focus on what your muscles are actually doing, which does help with the whole engaging the right bits sort of approach. So TENS machines, only real contraindications, I think, are certain types of severe epilepsy, if you have surgical pins that extrude out through the skin, or if you're actively undergoing chemotherapy at the moment. So if any of those apply, speak to your specialists first. If not, I think safe for most people. So you can just pick TENS machines up from chemists now. They're all over the place. So it's definitely worth a try if you haven't tried it already. I'm looking for advice for my 16-year-old son, hypermobile EDS, whose small fingers appear to be out of position all of the time at the middle joints. I would strongly recommend a hand therapy referral. Rather
Hmm.
conveniently, I think I've got a hand therapist joining me in about 3 months time on this. So if you haven't managed to see a hand therapist, that might be one we can bring back there. But definitely off to the GP for that one. Have a little explore in terms of imaging, maybe, but also in terms of a referral to a hand therapist, I think.
Yeah, I'd agree. And if there are any supports that you can wear, just to provide the fingers with a little bit more support, and maybe something. Don't jump to treatment straight away. Definitely get an assessment. I have a physio who works with me, who does hand work as well. So happy to help.
Bed is also my office. I need to make it look less so. Throw blankets, solve everything, honestly. If that doesn't work, try cushions. Struggling a lot with my hands, fingers, orthotics pending, ring splints. The insoles for my flat feet have been difficult to fit into shoes, sadly, and orthotics have knee, wrist, and ankle supports pending. If you're not getting on well with things that have been provided to improve your life and they're not improving your life, please go back. Go and tell somebody that they're impossible to fit in shoes or they're awkward or they're not giving you the right support. I think all too often when things aren't great, we just kind of put up with it and we shouldn't. So go back, demand better. And I hope your next round of orthotics actually does the job. Fingers crossed. Anything to add there?
No, I was going to say the same.
Lovely. Please could you share your bed desk? So mine actually was from NRS Healthcare, who went bust recently. So I cannot share a link to it, but there are a couple popping up on selling sites like eBay. So if you search for overbed desk, you will get quite a few options from various places. I would specifically recommend one that goes all the way over and has supports on both sides. Otherwise, as soon as you put a laptop on it, the whole table just kind of drifts downhill and your pens roll away. But yeah, hopefully that helps a little bit. I need help with moderate to severe neck pain. A few weeks ago, there was a loud pop when I moved my head, and ever since then, in pain. Been to GP, who spent most of appointments explaining hypermobility to me, even though the diagnosis is years old. Told me it will take 6 to 8 weeks to feel better, but every time I move my head, it feels like something's clicking or catching in my spine by my skull. Any suggestions?
So I often find that it's either underdiagnosed or overdiagnosed. So you've got a GP that knows their stuff, but they also don't want to really help the neck. Sorry, I'm sorry to hear about that, first of all. So yes, it might be that I suppose the GP was going probably down the tangent that you're more likely to hear pops and things like that. But if the pain hasn't subsided, which it hasn't, then it may be that it has, you've either pulled a muscle or there's a strain there that needs to be looked at. And if you're happy with hands-on treatment, then I would definitely go to a therapist, a physiotherapist, to have a look at what's going on. If it's a nerve type pain, so you mentioned kind of pain coming down into the spine, if it feels like gnawing and nervy, then it could be that you've got 7 nerves coming from your neck, and it may be that one of them might just be a bit pinched. If it's going down into your shoulder, then that may be a muscular issue or a nerve one. So a muscle normally feels like an ache, and it doesn't go away, or it might come and go. So a nerve pain is, and also a muscle pain is when at rest you may not have it. A nervy pain is there. It's a little bit more intense. It feels like you might need to take something for it, but it doesn't help. Even if you were to able to take some kind of anti-inflammatory type drugs. So I would say very, very gentle movements to see what's supporting and what isn't. Avoid going into extreme movement. So if it's painful to look up, then don't go all the way, but allow yourself a very small amount of movement. Don't stay stiff because it will become stiffer. We talked about protection of joints earlier, so keeping your joints warm, not necessarily fixing your neck with a brace, but having a scarf around it. Often with our conditions, Heat would be better than ice, but we say not to use heat in the first 72 hours, but it sounds like it's past that. So if you can keep it slightly warm and comfortable, then please do. Also pillows. I often have patients that have too many pillows for their own good. It kind of closes the tongue. And if you find that your tongue is at the top of your hard palate, you're already closing down the back of your neck where your tongue is attached to kind of at the, towards the back of your skull. So think about how you are sleeping. If you prefer one side, it doesn't matter, just be comfortable. Try to reduce the height of your pillow. And then think about when you do that, where is your tongue? Your tongue wants to sit in between the teeth, ideally at the lower part of your jaw, but not to the top of your hard palate, because that will then, as I mentioned, it can make your neck worse. I think that's it.
I'm just overly aware of where my tongue is now. Like when you talk about posture at a conference and the whole crowd goes, you?
Yeah, exactly.
Yeah, I definitely think that's good advice. I think generally you're right. There is a tendency to go either over or under in terms of the amount of treatment you should be getting. I have a set of rules in terms of self-managing things versus going to get things looked at. And the first one is this a new thing? If I haven't experienced this before, even if it's a symptom that is associated with my diagnoses, I will get it checked. The second one is having done all the self-management stuff that I know how to do, are the symptoms still disabling me? Are they still impacting my ability to function in a degree that I'm not happy with? So if that's the case, if your pain is such that you can't function the way you normally would, despite taking all the right precautions, go back, get it seen again. Other things to consider are actually how long has this been going on? Is the expected recovery period past, or were you, do you know, if we're saying 6 to 8 weeks here, if we're at week 4 and you've had no improvement whatsoever, as an example, I might be a little bit like, maybe I'll just make a phone call, maybe I'll just self-refer to physio, see what's going on. Every healthcare professional ever who is even remotely worth their qualification would rather you went back if you're not sure.
Yeah.
So if in doubt, get a second opinion. You can self-refer to physio. You can, go and see a different GP, or just go back to the first GP and say you're not comfortable with, what's been said. So if in doubt, go back, but definitely try some of the pain management stuff. Looking at your pillows is a great idea. It's a bit weird, but getting somebody to take a photo of you as you would normally fall asleep can be really, really useful, because often what we think is comfortable, when we look at the picture, we kind of go, oh, actually, now I see why I get neck ache and back pain and my hips are weird. Yeah, photos are a useful way to be able to reflect on what our bodies are actually doing up to. So, yeah.
And actually, I often get people to take photos of their work setup, their workstation, where they are in their day to day, because that then gives clues as to why they've got the pain.
Yeah, lovely. Where are we up to now? Sorry, I'm getting messages from multiple chats, so it's kind of all over the place here. Any tips on possible cubital tunnel syndrome with hypermobile elbows? So far, I'm alternating between bracing and physio exercises that they've found online, ice packs and heat packs, but it's still causing pain all down my arm, and I expect it'll be months before I get any medical input.
Oh, that's an interesting one. So, I would probably say, going back to posture, if it's recurring and nothing so far is helping, we've got two options. Definitely look at how your body is day to day. So look at your sleep pattern. We talked about pillows. Look at where how are you sitting, how are you standing, what are you doing with that arm generally day to day? Because often it could be down to just literally having your arm on an armrest or on a table. I often find that when I'm sleeping, if I've got my arm in this position, that's already stretching the ulnar nerve. So I will wake up with pins and needles. So look at how you are managing day to day, because it may be a very simple tweak that you can make. Or are you wearing, is it a tight bra strap, for instance? Have a look at what you're wearing and how you're wearing your body in terms of posture. The other thing I would say is second opinions. So if it's not helped with one person, then maybe try another. Because often it may be that somebody else has a different idea of how you can either set up your home station or give you some muscle release, techniques or hands-on treatment to try and kind of help manage. It's always not just about the elbow. We always look at the joint above and below. I would also, with our conditions, also look up to the neck. So what's your neck doing? What's your jaw doing? Are you clenching somewhere else that's then almost providing an associated pain? There's so much you can look at there. I would definitely go back to either the person that you've seen already or go and get a second opinion to see if somebody else can see something that they've missed.
Very sensible, thank you. I don't tend to have pain during exercises, but my joints scream at me a few days later. Is there a way to know what is too much in the moment, or is it just trial and error? Pacing. I'm going to come back to pacing again and again and again. You're probably all sick of listening to me talk about it at this point. One of the things I think are really useful are micro breaks. So all I'm talking about there are like 10 to 30 seconds of not doing the thing you're currently doing.
Yep.
So in between sets, when you change exercises, when you grab a drink. One of the things I would encourage you to do in all of these breaks is a little bit of a body scan head to toe. Are you hungry? Are you thirsty? Are your arms and legs attached? Are you feeling a little bit wobbly or jittery? Do you feel like your muscles are cramping a little bit? Do you feel kind of heavy or tired? Is your heart rate through the roof? All of these things are going to have an impact on the overall outcome in sort of 48 hours time. So just being slightly more body aware and giving yourself more breaks to actually catch up with what you're feeling is my first piece of advice always. My second piece of advice is that you're better off doing exercises once and doing it well than you are doing 50 reps of anything badly. So do less, do it perfectly, build up gradually rather than starting with loads, doing too much, paying for it, and then having to progressively scale back.
Yeah. I 100% agree. And also you mentioned earlier about kind of keeping a diary or journal. I often find that going back to that, so sometimes I forget about what I've tried, and going back to kind of the things that have worked, I will then stick to. So and sometimes it's just try one thing, just perfect one thing. That's enough to allow the body to get used to it and go slow with it.
Yeah. Yep. So it's a follow-up question from back and hip pain thing. I think this one might be a little bit specific for this setting. So this Jane again had extreme problems after hip replacements at the age of 43, left with one leg, yeah, with a 1.6 leg length difference. Now cannot walk, have swaying from pelvis, SI joint issues, symphysis pubis issues, and knee problems. What can I do? I have to use a wheelchair. I think this needs this isn't really like a we can fix it via the internet kind of this. You need like a hands-on assessment with somebody there. So I would be really looking into particularly kind of orthopedic or like back and neck services for this to really get like a proper full-on assessment, and then to hopefully have somebody help you come up with a plan for maximizing the function that you can. I would also strongly suggest a referral to pain clinic if you haven't had one already. Pain clinic often will have pain specialist physios, but also have access to clinical pharmacology teams, OTs, psychologists, all kinds of other stuff going on. So pain management would probably be a really good starting point before we chuck anything extra in there as well. Any advice?
Often, so the surgical appliances units, which are fewer and fewer in hospitals, would make up boots, so that you'd get like you know, for the leg length discrepant side would be a longer or a bigger shoe. Having said that, they only increase it by once it's three centimeters or greater. So they would look at that and say it's not significant enough, although it is for you, of course, because it's creating all sorts of kind of compensatory issues. So I would say, on top of what Joe was just mentioning, just finding something. So there is the treatment I mentioned before. We do raise one side when we have seen a lot of patients that have had a significant difference between the left and right because of things like osteoarthritis, post-surgery, and pre. And it has helped because it's kind of almost providing a little bit of a support when you're, you know, through your rehab plan. Maybe even trying just an insole, so going, you know, actually having an insole made so that it can be inserted into one shoe, or having a trainer built up on the side that's lower, will help to manage the asymmetry.
Lovely. What can occupational therapists offer for heads and CFS? I had a very brief OT appointment a couple of months ago, and all I was given was an explanation of and recommendation of pacing. Maybe that's all there is, but I was wondering if there's anything else. Okay. Disappointment on behalf of my peer there, but there we go. So this does vary from service to service and from therapist to therapist. I can only speak for me personally, so pacing would be one of the things I look at, but I also look at joint protection, understanding pain, education around safe movement strategies. I'm a certified fitter for DM orthotics, so I often facilitate referrals to get like compression garments made on the NHS. I look at aids and adaptations in terms of pieces of equipment that might be useful. We can have conversations about mobility aids, whether that's appropriate. If it is appropriate, where can you buy them from? What should you be looking for? I often do sleep hygiene advice as well as advice on managing like positioning overnight so you're not getting too many injuries. Quite a lot of stuff on splints and braces, writing aids, adaptive crafting. I recently launched a service for managing heat intolerance during heat waves, so that was quite popular over the summer. Flare-up planning is another one, which is quite a good one. So literally having an on-paper, tangible plan for what you do in the event that one or more of your symptoms throws a temper tantrum. Personal shopping for mobility aids. There's a lot of stuff. Basically, the thing with OT is that it's supposed to be facilitating your ability to do the activities that you enjoy, whilst also recognizing that doing things you enjoy has an inherent therapeutic benefit. So essentially, if there's a thing you want to do but can't, an OT should be able to, in theory at least, help you to achieve that, whilst also recognizing that if we don't have time for joy in our lives, our mental health is going to suffer for it. So yeah, hopefully that answers that one. Sorry, this is a little bit awkward because I've got messages coming through in 3 different chats and they're all in a very weird order. What can we fit in? I have a distal radio-ulnar pain, primarily in the connective tissue between the two bones, and MRI has shown up arthritis in the wrist. Standard pronation and supination, physio exercises have made it worse, so now my consultant wants to put a steroid injection into the lateral wrist joint. I don't think this will help, but it's likely to make things worse. Are there alternative physiotherapy exercises you could recommend?
So it's an annoying place to have pain. And limitation, because most of the exercises that would be given as standard are to kind of flex, extend the wrist, or kind of supinate, pronate, or do the laterals. I would say if that is causing an issue, then do the things that are allowing your body to stay in that position. So we've got someone's sunshine in my pocket. Thank you. So I would try as much as you possibly can to keep everything in neutral. And that goes for any joint, any area that seems aggravated for any of us really, is to keep the joint in neutral and then work on maybe thumb movements, slight finger movements. You can use bands to kind of open and close the wrist. Well, that kind of works my hand already. Making fists and things like that. Making dough, so making some bread, things like that that are more functional would probably be better for you. And as I mentioned earlier, always looking at the other joints. So it may be that the issue is with your wrist, but also supporting your elbow, supporting your shoulder and your neck and head as well.
One thing that might be worth looking at is night resting wrist braces, basically. So one of the issues I found with a lot of my hypermobile patients is that we have a tendency to sleep in really not good positions. So like curling up, and if you're folding your wrists over at weird angles while you sleep, it may be contributing to the pain that you're experiencing there. So a referral to orthotics would be sensible. They basically make braces that are super padded, really, really chunky, and they just Velcro on. And the aim is to hold your wrist in a nice neutral position so that you're not doing damage while you're unaware of what you're doing. And then you would carry on with your daytime rehab stuff as per usual. So that might be worth a go. You can also try just sleeping with like hugging a pillow or laying your wrist, but basically putting your hand inside a pillowcase so that you're effectively strapping your hand to a pillow to ensure that you're not kind of curling yourself over. But that might make a little bit of a difference. In terms of steroid injections, I have just had this conversation for a different joint with my own specialist. Steroid injections serve a purpose, and that purpose is to give you a window of reduced pain, during which time you can push harder for rehab and hopefully make enough progress to overcome the thing that you're having an issue with. However, really, you have a limited number of those. And if we're dealing with a lifelong condition and we're using up all of our steroid jab options in our 20s and 30s, it makes symptom management when we're like 30, 40, 50 a lot harder. So my specialist has said 3 per joint is my absolute limit. After that, you're drastically increasing your risks of catastrophic tendon rupture, was the phrase, which obviously is not good when hypermobile people aren't exactly great candidates for like reconstructive surgeries. So I wouldn't flat out rule out steroid injections for most people. It is a thing that might come in handy, but I would do so cautiously, and I would not have it done randomly by somebody in a clinic. I would have it done by an orthopedic specialist with ultrasound guidance to ensure that you're getting a good one, and to make sure that you've got a rehab plan in place for that afterwards. So you would have the jab done by a specialist. You would have 3 days in a brace completely immobilized to wait for that to kick in. And then you rehab, and you rehab fairly intensively and with fairly close supervision to make the most of it. Otherwise, you're wasting one of your 3 options, basically. So
Yeah.
hope that's sort of useful. I don't know if you agree or anything to add
Well
on
said.
that one.
Yeah, absolutely.
Yeah, lovely. Okay, that is us time-wise. I'm drastically aware of the fact that we have rather a lot of questions left still. So what I would love to do is actually have you back another time, if
Lovely.
that's okay. And what I will do is any questions that I can answer, I will answer in my next live stream on my own. So basically, I'm going to rack up a load of questions until after I've had my next few round of guests, and then we'll see what we can do.
Great.
But if we keep going as we are now, we're going to be here till midnight. So I hope this has been a really useful session for all of you. Thank you all so much for coming, for your questions and comments. If you do have a minute to spare, it would be really great if you could fill in the feedback form, which a link will probably appear for shortly. Any feedback you can give us does help us to make this better. It helps us to choose who we bring on, what advice we're giving out, how we can kind of cultivate a really useful thing for you all. And it also occasionally helps with fundraising, which is super useful too. So yeah, thank you very much, everyone. I will see what I can do about answering some of these another time. And apologies to anyone who didn't get their question answered, but it was obviously quite a busy evening. Yeah, thank you very much for joining me. It's been really amazing having your advice here, and I would love to have you back again.
Thank you, Jo. Thanks for having me, everyone.
Okay, guys, take care. See you next time, hopefully.
Bye all.
Bye.